Thank you very much. I hope you can hear me at the back. Yes, I see people nodding. Delighted to change titles, but this topic is a bit more conceptual, a little less driven by data, because I'm being asked to talk about the impact of pH in other fields, and especially in progressive fibrotic diseases and PPF in particular. This needs a lot more exploration. So broadly, I should give you my conflicts. You can see that I can name all but one of these for good reasons. When I get paid by one company, I will acknowledge them. So this is really 4 5-minute talks. I'm taking pH and thinking about what is the key diagnostic implication in each of these two areas, and what are the key management implications. And I'm going to start with diagnostic implications of pH in connective tissue disease. Now, it will probably strike you that this is not a logical title because, by and large, in the formal definition of connective tissue disease, pH is not a requirement. So surely impact on diagnosis is non-existent. But the setting where this matters, and it leads to huge confusion, is the thing called IPAF, interstitial pneumonia with autoimmune features. And this entity was first promulgated over a decade ago. The working group published finally what was a research statement. And so IPAF around the world, technically a research entity, has in some groups been turned into a validated diagnosis. It's the quick gin and tonic for the clinician that doesn't like uncertainty. They can turn uncertainty into an acronym and call it a diagnosis. But it's a very difficult area, and to satisfy criteria, you need to have 2 out of 3 domains that are satisfied, and one of these 3 domains is the morphologic domain, and if you are to satisfy that, probably the most frequent criterion is unexplained pulmonary vasculopathy. How useful is IPAF? Well, to justify its existence, a new entity logically needs to provide utility. Utility in prognostic evaluation, utility in identifying a different treated course, utility in allowing us to know what to say to patients and what to do to patients. And especially when something's a research entity, you really need to tick that box. Now, I've tended to use this study, the largest study in debates, to argue that IPAF is not fit for use. And this is a very large cohort. I'll see if I can work this pointer of patients either meeting IPAF criteria or else criteria for IPF or connective tissue disease with ILD. And what I want you to focus on is the green and red lines. This is survival for those patients with IPAF that have UIP versus those that have IPF, identical, almost supernaturally similar. So what use is IPAF? And this is where pH becomes crucial, and where in fact there is a fatal flaw in this study that perhaps a bit dishonestly I haven't highlighted in debates. Seems to have been missed. unexplained pulmonary vasculopathy, what did the authors do? They took the whole cohort. They used an inflexible FVC over DLCO ratio of 1.6, and they used that to specify that you met the multi-compartment criterion, and therefore many patients were categorized as IPAF. Now, this diagram shows IPF patients with and without emphysema. And you can see with the open circles being emphysema and the solid identity line, that if you have even a whiff of emphysema, you tend to have an FVC over DLCO ratio above 1.6. But furthermore, the black dots, those without emphysema, the identity line, if your ILD is bad enough and you run out of blood vessels, then you will develop pH and you will have a high FVC DLCO ratio. So this widely cited series moves the patients with IPF with the worst outcomes, pH as well, into the IPAF. It improves the IPF outcome, it reduces the IPAF outcome, and it leaves us confused. Now let's take a deep breath, because I'm saying that I do not believe IPAF is fit for use, but it is a great starting point for the multidisciplinary diagnosis of CTD-ILD. And our diagnoses are inflexible if we use IPAF. But our ethos is multidisciplinary diagnosis, and therefore forgetting about IPAF, it becomes pivotal to understand pH and pulmonary vasculopathy in general if we're going to diagnose CTD-ILD based on multi-compartment involvement. And it does not consist of an inflexible FVC over DLCO, but understanding whether there is vasculopathy, which does not necessarily mean pulmonary hypertension, and then working out in multidisciplinary discussion whether it's clear, as it often is, that it's disproportionate. And just one slide to close this first longest of the 5 sections. This is a patient with scleroderma who, as it happens, had ulcers and received prostanoids for ulcers. What is missing is a normal right heart study, which was done after the second dot. And you can see that you have a low KCO to start with, you have a falling KCO, and with a normal echo, and then about 9 months later, the first right heart study normal, you have falling KCO, you have a vasculopathy present, you don't have to have pulmonary hypertension, and then eventually this patient did develop pulmonary hypertension confirmed at a right heart study. Second point, progressive pulmonary fibrosis. It's radically changed interstitial lung disease, and I think we can view it as a disease behavior diagnosis. It's one of the 5 patterns of disease behavior in chronic ILD. And as we all know, in CTD-ILD, there's often disproportionate vasculopathy, and therefore, in these patients in particular, you've got to be sure, if you think this progression of interstitial lung disease, that you are not dealing with progression of pulmonary vasculopathy. This leads me to this guideline. Now, I can see good things in the guideline, but I have to tell you that the definition of PPF is a dog's breakfast. And I'll tell you exactly why. You've got 3 criteria, and you must meet 2. Worsening respiratory symptoms, worsening of imaging, and then 1 of 2 lung function criteria. And one of them is an isolated reduction in DLCO. And so if you have a combination of an isolated reduction in DLCO, you haven't got FVC, that's why you need to use DLCO in this schema in a patient exhibiting this feature. Isolated reduction in DLCO is actually proposed at the moment as part of an index for identifying pulmonary hypertension, progressive vasculopathy in ILD. And if this is there, you will get worsening dyspnea. So DLCO in our practice has been confusing about how to use it. It's very logical to combine it with FVC. Some of the time, you have apparent change on FVC, which is potentially measurement variation. Sure, DLCO may be highly nonspecific, but you expect it to fall when there's significant progression of ILD. And so, if you are in doubt, it is valuable to have a second measure made independently with its own independent measurement variation, and it helps immeasurably to be confident that decline is real. That's how we've used it for decades, and that's presumably why the guideline group discarded this approach. Common sense is for common people, but actually this is how it tends to be used. And so the guideline recommendation is that isolated serial reduction in DLCO plus increasing dyspnea equals progression of fibrosis. And in CTD-ILD, this paradigm for a progressive pulmonary vasculopathy, I suggest, is madness. Now, the guideline states that you should use serial CT in this scenario based on reviewer comments. Well, you might as well say, let's define PPF by change on CT plus dyspnea. But you have to get lucky. Your first scan needs to be done at the start of a DLCO trend, which almost always it isn't. And the second one when you're actually examining the trend. I'm on to the third one of my 5-minute talks now. This I can be brief in. Pulmonary hypertension and CTD, stray management thoughts. And I guess this is very similar to PH in general, but it has to be amplified somewhat in CTD because there are more often odd pathways to pulmonary vasculopathy in CTD. And I think you have to start, is it due to cardiac disease, obviously? And you can separate that into a larger group where you're talking about left heart disease with, say, ischemic heart disease, hypertension, the range of respectable cardiac diagnoses. And then you also have to think about the CTD directly affecting the left side of the heart. What you do know, and this is most clearly shown in the sarcoid pulmonary hypertension registry, 20% of patients had left heart disease, usually not cardiac sarcoid, but more traditional heart disease driving PH, and they had a vastly better outcome because of all the things you can do that are effective for the left side of the heart. Cardiac fibrosis, under-recognized in scleroderma, but probably most prevalent with inflammatory myopathy, and a useful rule of thumb, and I stumble across this a lot, managing patients with inflammatory myopathy, people are not thinking about cardiac disease, but anything you can get with cardiac sarcoid, you can get with cardiac involvement with inflammatory myopathy. And it's often severe. It's often life-threatening when it occurs, and it is a crime to miss it. I'm just going to touch on a few isolated things. The one that I have least certainty about is pulmonary hypertension in lupus. Direct cardiac disease is quite rare, but you shouldn't overlook it. But This is a disease in which it seems that in a significant minority, and in the older studies, mixed connective tissue disease, you can add to lupus, you get responses in some patients, major responses to anti-inflammatory therapy. So you really are dealing with a pulmonary hypertension setting driven by a vasculitis. And you can actually see, for example, resolution of right ventricular dilatation with immunosuppressive therapy if you get really lucky. Anticardiolipin antibodies, terribly common in lupus, with thrombotic episodes. And then the phenomenon of vasospasm, which is very, very difficult to diagnose. Severe dyspnea with inhalation of cold air, widening of the AA gradient with a cold air challenge, often responding to calcium antagonists. So the management variably requires immunosuppression, anticoagulation, treatment of pulmonary vasospasm, cardiac therapies, and then you might be dealing with a PH-ILD, where you work out that it's disproportionate and you end up using the sort of algorithm you would use for group 1. And that, in fact, is probably the point that in CTD, you really have to cast the net very wide. More often you have weird pathways to pH than you do in idiopathic disease, and you won't manage pH well unless you actually pursue these fantasies and isolate vasospasm, anticardiolipin antibodies, think through which patient might respond to immunosuppression. And so that sums up the third theme. Management implications, they're all about understanding the often weird underlying cause and combination of factors. And what I will add here, and it's true of the fourth, beware of obstructive sleep apnea. I was delighted to hear the theme of the last lecture. I think we have enough evidence that is indirect that whether or not OSA by itself would have caused PH in these patients, it's probably a powerful ancillary factor, and indeed nocturnal desaturation in general, a powerful ancillary factor in disorders with a predilection for vasculopathy. We know that with overnight desaturation in ILD, you get surges of endothelin, arterial endothelin. You have upregulation of various pathways. So in the mix is a powerful factor. Now I'm going to close with management implications of pH in progressive pulmonary fibrosis, and I've already dealt with one. If you don't think carefully, you will call what is progressive vasculopathy, you will call it progressive fibrosis. And that leads to mismanagement. Item 2, you really need to identify pH because it becomes a priority for transplantation. Because it is such a major malignant prognostic determinant, and we know in non-IPF progression of fibrotic lung disease, to have progression in spite of traditional management itself is making you think along the lines of transplant. And you are crossing your fingers and you're using antifibrotic drugs. But if you have pH as well, you have to prioritize transplant. Indeed, this is recognized around the world. In the United States, the priority score for transplantation having pH is a very big deal in ILD. Of course, this does indicate, if you're going to use this, that you are not using it too late with a failing right heart, because transplantation does tend to be very bad news in that setting. And I'll make the same point, which is appropriate because CTD-ILD contributes a fair proportion of patients with PH. Understanding the cause is crucial. If you are dying of PH, it is questionable whether you should subject patients to the unpleasant side effects of antifibrotic drugs. Existing drugs are not generally dangerous, but they do affect quality of life. But if pH is not end stage, I think there would be a consensus that antifibrotic therapy should be used quite urgently to slow disease down and perhaps buy time for transplant, perhaps allow in some patients, the right patients, a group 1 treatment algorithm to be put in place. And so I will close with a slide that may change everything that I've said. It's a slide that I think will be shown repeatedly and was shown repeatedly in the last 2 days. Treprostinil, inhaled treprostinil in fibrotic lung disease. And I'm not going to speak to it because people have already spoken to it and they will speak to it. But what I will say is this. We don't yet know this is going to be a landmark trial. We've been disappointed too often in fibrotic ILD. I believe based on the open label study, it probably will be. I am going to highlight caution about another aspect of this trial, which is the post-hoc impact of this drug on FVC levels. And you can see here with active treatment in the whole group, the impact of FVC wasn't significant, but it certainly was in the idiopathic interstitial pneumonias. So this, if it's correct, and this is the trial I'm much less confident of being reproduced, it's post hoc, but if it's correct, we will actually have a therapy that acts jointly on pulmonary vasculopathy. Somebody wants me to stop speaking, I think. I'll just get rid of it. I'm actually in about my last sentence, I think, so be reassured. We will have a treatment that acts jointly on vasculopathy and progressive fibrosis. And so you can read my summary conclusions. There's one sentence for each of my 5-minute talks, and that is what I have to say.